Apples tend to spoil the whole basket. PowerPoint is difficult. Kenya uses Apple, so I thought it will be convenient. What do we have? So following that hiccup, let's get on to the business. So anatomy of the nasal framework. As I was talking, nose occupies the central part of the face, and hence it tends to draw attention if there are asymmetries or any deformities or something away from normal. Now, as face is the index of man, nose tends to be the index of the face if it is not proper. Can I have a pointer, please? She is a very famous actress, and then she does have a nasal deformity. So automatically, our vision tends to go towards the nose because of the deformity. And the idea is that the nose should blend into the face and should not draw attention. That's the premise of having a beautiful or attractive face. How many of you in the audience say she is attractive? I want a raise of hands. So, not just in the eye of the beholder, but attractiveness has a quotient. It's an universal quotient. It's an acceptable quotient that 70% of the population tends to find the same things attractive what the others would find. It's norm. So we move on to the framework of the nasal anatomy, and as is evident for any three-dimensional structure, we need a good, robust framework. The framework is provided by paired structures in the form of bone in the upper one third and cartilage in the lower two thirds, and it also has a soft tissue covering and surrounding structures which are vital for the face. The soft tissue envelope consists of skin, superficial fatty layer, fibromuscular layer, a deep fatty layer, and perichondrium, followed by the cartilage and the bone, respectively, in the different parts of the nose. The SMAS layer constitutes the superficial musculo-aponeurotic system. Now, this layer is very important because it does carry the nerves, it carries the blood vessels supplying the tissues over the nose, as well as the musculature which comes onto the nose. So, the layer of dissection in rhinoplasty needs to be in the avascular plane, which is just deep to the SMAS layer, so that you can save all those important structures, which will prevent problems like skin necrosis, loss of blood supply to the tip of the nose, your loss of sensation because the nerves getting damaged, or preventing a bloody field as you operate. The skin over the nose is very important for the rhinoplasty surgeon, mainly because skin tends to vary in various ethnic groups. Most of us tend to see rhinoplasties books which are written by the Westerners, and their skin differs largely from what we in India tend to encounter skin as. Skin which is thin has an advantage that we hardly leave a scar in them, and they tend to heal very well. But the flip side of a thin skin, as is evident in the last slide here, of underlying structure. So, post surgery too, whatever defects tend to be there, they tend to get highlighted, as against the Indian skin, which tends to be very thick and it camouflages the entire framework which is underneath it, and hence may not be very clearly evident despite our best efforts in rhinoplasty techniques. The blood supply of the nose is important mainly because today's generation we tend to do a lot of external rhinoplasty or open rhinoplasty approach techniques, where we will use an incision in the columella. The blood supply to the tip of the nose is largely from the columnar branch of the facial artery. Incision in the columella, we are cutting off the two arteries which are supplying the columella. So, the tip gets blood supply only from the superior branches and the lateral branches. But rhinoplasty also involves us lifting the SMAS layer. So, if you go through the SMAS layer instead of going underneath the SMAS layer in the avascular plane, you tend to cut off blood supply there too. And as you are doing your lateral osteotomies, if you are in the wrong direction and you cut off your blood supply laterally, the tip is devoid of any blood supply. Hence, there is a big chance that your skin healing in the tip of the nose can get altered or sometimes even lead to necrosis. I would skip this slide only for academic interest. Move on directly to the upper third of the nose. In the upper third of the nose, you find the bone, the nasal bone. The nasal bone is superiorly attached to the nasal process of the frontal bone, and it is described as a leaf-like structure which is broad superiorly, broad inferiorly, and narrow in the middle. Ideally, the nasal bone should occupy about 75% of your intercanthal distance. Now, these two are articulated in the midline, and the suture, which is the nasofrontal suture line, is also called as the nasion. Now, the nasion is one of the landmarks for rhinoplasty surgeons in the evaluation of the nose. Now, deviations in the nasal bones are usually bony, so obviously you need to break bone. So, hence it will require osteotomies. That means you need to cut bone to try to make it straight or correct the deviations. Minor deviations can always be sorted out by doing something like rasping or sometimes even camouflaging by using augmentation techniques. This is an example of the nasal bone being deviated slightly towards the left, and then that has been corrected with osteotomies and complete rhinoplasty. Now, the middle third of the nose is largely formed by paired cartilages called upper lateral cartilages. They are trapezoid in shape. They are attached superiorly with the nasal bones to such that they go under the undersurface of the nasal bone, and the connection can vary from a few millimeters to up to a centimeter, and then medially it is connected to the nasal septum. Inferiorly, it sort of locks onto the cephalic border of the lower lateral cartilage in a scroll. That is, it can tend to bind to one another this way, again to various degrees, and laterally it is connected to the piriform aperture with fibroconnective tissue. And the upper lateral cartilage gives what is described as the brow tip aesthetic line. So, when you see a person in oblique view, it has to be gracefully curvilinear, symmetrical and unbroken. So, any rhinion, the junction of the upper lateral cartilage and the nasal bones, and in this area tends to break this curvilinear unbroken line and it can get broken. Sometimes when people undergo surgery for rhinoplasty and the upper lateral cartilages are sort of avulsed from the nasal bones, they tend to collapse. This leads to a deformity called as an inverted V deformity. That is, this goes down, and then hence become more prominent. Hence, you see an inverted V type of vision when you see a person in the frontal view. So that tends to get accentuated. The middle third in the frontal view, when you assess the patient, if you find it's pinched, if it's very narrow, then there is a possibility that the patient might be having a internal nasal valve dysfunction too. Now, the internal nasal valve is an area which is between the septum and the upper lateral cartilage. Ideally, this should be at least 15 degrees so that a patient doesn't experience nasal obstruction. So, a preoperatively pinched middle third will mean the patient's nasal obstruction is probably contributed by a internal valve dysfunction other than all the other causes of nasal obstruction coexisting. Now, this is usually solved by what is called as a spreader graft, which I am sure my other colleagues will be talking about in their lectures or during surgery itself. As we transit from the upper bony structure to the mid cartilaginous structure to the lower cartilaginous structure, there are two areas which are important. The transition zones are called keystone area and the scroll area. The keystone area or the rhinion is the area where we transit from bony nasal bones to an upper cartilaginous zone. That is the upper lateral cartilage. From the upper lateral cartilage to the lower lateral cartilage, you find what is called as the scroll area. Now, these two are very important structures which actually support the entire nasal framework. So, disruptions there can alter the way your nose is held on the frame. So, the lower one third of the nose is formed largely by the lower lateral cartilages. The lower lateral cartilages are again leaf-like structures which has what is called as a medial crus, and then a lateral crus and an intermediate zone or the intermediate crus. Now, as you see this leaf-like structure, this actually diverges away on the inferior part. This is what is seen on the basal view on our columella. Sometimes it can look very broad because it tends to diverge away from the midline, and then as it traverses up, it curves, and that forms what is called as the dome. Now, the dome on either side gives you your prominence on the tip, and as it goes laterally, the angulation of the lateral crus can be different in different people, causing different bulbosity of the nose. So, the other thing that we need to see in the lower lateral cartilages or in the tip area is what is called as the soft triangle. Now, the soft triangle in the basal view is the area where the lateral crus and junction in this area is devoid of any cartilaginous support. It's purely only by skin and subcutaneous tissue. Hence, care should be taken during your surgery that incisions don't go across the soft triangle because it tends to leave a bad scar. So, neither should sutures go through this area nor your incisions. So, when you have a look at the frontal view of a patient, the tip, you find something called a diamond. This is called the aesthetic diamond of Sheen, which is largely constituted by the supratip break, infratip lobule, and the two prominent tip defining points which are produced by the domes of the lower lateral cartilages. So, this would be an ideal picture for most people to have in their frontal view. Basal view, ideally that entire base, if it is about 1 centimeter from one alar wing to the other alar wing, 0.6%, that is 60% of the alar width. I think this I have already said. So, look at the tip, it will look like a lateral triangle on basal view. Be an ideal configuration, and on the frontal view should give you a well-in-flight appearance with hardly any show of nasal nares. Now, these paired structures, they all sit on an important structure which we all deal with every day, which is the nasal septum. Now, the nasal septum, as we all know, constitutes of a quadrangular cartilage, a perpendicular plate of ethmoid bone posterior superiorly, vomer posterior inferiorly, and the maxillary crest, and which ends in the maxillary spine anteriorly. Now, here there are a few. So, the septum is the pillar of the nose. There is an adage which says, as goes the septum, so goes the nose. So, if your septum is straight, your nose tends to be straight. If your septum is curved towards one side, then in all probability you will find your nose dorsum also moving towards the same side. So, a few things that we need to be aware of are what are called as septal angles. Now, the anterior septal angle is the point at which the dorsal cartilage and the caudal cartilage meet, and this has significance because that is the one which supports the entire dorsum for you, and it is also a landmark for open structure rhinoplasty surgeons to identify the septum so that they will be able to reach it once they split the lateral lower lateral cartilages. And then the second thing is the posterior septal angle. The posterior septal angle is where the caudal septum goes and sits on the maxillary spine. So, if it is not in the midline, it gets deviated towards one side. So, your columella, you will find that is either asymmetrical or you will have a caudal dislocation of your septum, which is described in clinical terms. A few things that we need to be aware of when we assess the nose are the photographs that we tend to take and assess. How should they be taken? So, the ideal for a lateral view or a profile is to take photographs in what is called as the Frankfurt horizontal position. This is such that the alignment of the upper point of the external meatus and the inferior orbital margin should be in one line. They should be horizontal to the ground. So, that way you tend to have a symmetry in all your assessments, as well as you do not get angulations. In the frontal view, so your frontal face is divided into 3 parts vertically and 5 parts in the coronal plane. So, the face is divided into 3 equal halves at a line going through the glabella, subnasal and chin. So, these 3 should be proportionate, they should be equal 1/3. So, obviously here you can see that the third is very small as compared to the other 2/3. So, obviously in this patient she has a very short nose for her face. Divide the face into 5 symmetrical vertical halves or 5/5 based on the intercanthal distance. Now, the intercanthal distance has a significance for a rhinoplasty surgeon, that your ALR base should be approximately the same size as your intercanthal distance. Your nasal base is supposed to be wide if it exceeds the intercanthal distance. On the lateral view, we assess a few things. We assess for the nasal projection, how much it is projected anteriorly, tip rotations, is it a drooping tip or is it a tip which is rotated upwards, making it look very short, and of course the dorsal contour. When we say dorsal contour, you are looking for either saddling or a hump or any asymmetries along the dorsal contour. Few landmarks that we need to be aware of is the glabella. The glabella is the most prominent part of your frontal bone as it dips downwards into the nasal process of the frontal bone. The nasal bone and the frontal bone where they meet is called the nasion. That is the bony landmark. The soft tissue landmark is called a celion. The angle formed between the frontal bone and the nasal bone is called the nasofrontal angle. Ideally, this angle should be about 120 degrees. Then the other thing that we need to know is the nasolabial angle. The nasolabial angle is the angle formed by drawing a line along the lip margin as well as along the columella. This should ideally be between 90 and 95 in men and 95 to 105 in women. Now, what is projection of the nose? Now, you say you measure the projection of the nose by drawing a line from the nasion to the pogonion. This is called the zero median. And then you draw another line from the base of the columella to the tip of the nose. Just 2 more slides. So, ideally, this should be 0.6 of the, if you consider this as 1, this should be ideally 0.6. Or the other rough estimate is the distance between the base of the columella to the tip should be approximately the same distance as your upper lip. Now, the celion, as I told you, is the soft tissue reference of the nasion. This should ideally be in line with the supratarsal fold, but this supratarsal fold can be absent in certain ethnic groups. In those ethnic groups, what is usually taken as a reference is the eyelash line or the mid-pupillary line. The other thing that we need to assess in a lateral view is the small dimpling just above the tip called the supratip break and the infratip break. Look for how much the columella is showing, whether there is excessive columella show. So, these are few of the deformities that we can come across in our daily practice because of deviations or bulbosities which are caused. You can see that in this patient there is a deviation towards the left side. The tip is very bulbous. Similar these patients. These are the various tips that you can see. A bulbous tip here because of very thick subcutaneous tissue and deformity called as a box type of tip, wherein the lower lateral cartilages are divergent, giving a lot of space in between the domes. Hence, there is no tip defining point at all. So, this causes a lot of convexity superiorly, I mean that is towards the surface, and hence a box deformity. We also have a tip saddling associated with it. We do come across such gross deformities secondary to certain diseases. This person had Hansen's, causing complete collapse of the part of the nose. So, this is saddling deformity. Sometimes it can be congenital without any disease. You can still have saddling. Sometimes you can have congenital anomalies associated with nasal deformities like in cleft lip and cleft palate patients. So, because of not so well formed malar prominence as well as this part of the nose, you will have a collapse, asymmetrical nares, and base. You can have congenital deformities like a cleft in the nose, asymmetrical nares, long nose, hump nose, drooping tip, which has been corrected. So this has been corrected by Dr. Chidanand. So thanks Chidanand for some of the clinical photographs. So I now tend to do rhinoplasties on canvas. So this is one of my creations. So a thing of beauty is a joy forever. Rhinoplasty is one which will, if done properly, in good hands, not only give happiness to the person who is doing it and the person who has endured it, but also to the person with whom that person shares life with. Thank you. Thank you.
Thank you, Dr. Srinivas Murthy, for your detailed anatomy and its relation with the rhinoplasty. Thank you very much. Any questions?
I just asked, how do you correct the inverted V deformity if you create one?
First thing is to recognize it. There are various techniques described. I have not had experience of creating nor repairing it, but what I've heard from my colleagues, I think they are better.
So they say while you cut the upper lateral cartilage, it can cause it.
Correct, it can get
But
avulsed.
I have personally created mild deformity, not a severe one, by cutting the perpendicular plate of ethmoid high up.
Okay.
So
Inverted V, you mean to say the middle part, the
Yeah.
middle 1/3 of the
just
nose.
below the nasal bone. Yeah.
So what you can do, you can use the spreader graft. You can keep the spreader graft on either side. It will increase the width of the dorsum. And you can, if there is any depression lateral wall of the nose, you can put some plump graft, or you can just do some camouflage.
Okay.
That way you can correct.
By internal technique itself.
No, you can do it
Suppose you end up with it while doing a septoplasty.
Okay.
Then how do you, on table, how do you correct it?
While doing septoplasty, you land up in inverted V deformity.
Yeah.
This is what your question is.
Yes.
Okay. If possible, you can do it in closed approach. It is, I feel it is difficult. Okay, so what you can do, you can create a pocket in between septum and the upper lateral cartilage, and you can keep the spreader graft. That you can do.
Inverted V deformity, when it happens, hump production, excessive hump production, or keystone area, we damage keystone area. So there is a best way to correct inverted V spreader. Normally, after doing a hump production or osteotomies, the general practice is that in 75% of my patients, I use spreaders. Best way to correct inverted V. Second, you asked about septoplasty. As a rule of a septoplasty, dorsum strip has to be there. There is no need to damage a dorsum strip. If you damage a dorsum strip, there has to be a inverted V deformity. But again, the only way of correcting inverted V is putting a spreader grip. That is the best way of correcting the inverted V.
Yes, sir. We keep the dorsum, but sometimes when you have a high deviation with the perpendicular plate, you don't have any option but to cut it, the deviated part.
Happens, if you happens and you come to know on the table, make it open laterals, then put a spreader, that is a spreader. It's like laterals, spreader, septum, make a suture. And
Okay.
Hi, Dr. Satya.
I wish.
Yeah. So during a septoplasty, if you encounter a problem with inverted V, you Can do an endonasal spreader graft. You separate the upper lateral and the septum to the high point. Take a spreader from the lower part of the maxillary spine or the spur area. Design it. Put 2 vicryl rapid threads, knot it. Take the needle through the skin. So one needle comes up and the second needle also comes up. So the spreader goes and gets into position. You don't have to do an open rhinoplasty or a closed rhinoplasty for that. Sometime I can show you that.
Thank you.
It was a wonderful talk on anatomy of nasal framework related to nasal deformities. Our next session is a live surgery by Dr. Verendra Ghaisvas. It will start in a while. I thank the chairpersons, Dr. Ahilaswamy and Dr. Sridhar Reddy, sir. Thank you, sir, for chairing the session.
Hello, OT? Theater? Hello, OT?
Hello.
Hello, OT?
Yeah, hello.
Yeah.
Already the patient is intubated. Sir is infiltrated. Just now, sir will take over.
Okay, okay. We are getting the picture, OT picture.
Yeah, yeah.
I would like to invite Dr. Vishnuswarup Reddy Garu from Hyderabad and Dr. Jaskaran Singh from Amritsar to chair the session for this live surgery. I invite Dr. Sailaja to present a bouquet to Dr. Jaskaran Singh.
Yeah. Perfect. Yeah.
Dr. Jaskaran Singh Gill did his MBBS from Vinayak Mission Medical College, Puducherry, and completed his MS ENT from D.Y. Patil Medical College of Education and Research with gold medal. He published more than 15 publications as author and co-author in national and international journals. He underwent training in functional endoscopic sinus surgery, anterior skull base surgery, and rhinoplasty under Professor Heinz Stamberger. He has a fellowship in rhinoplasty and fascioplastic fellowship under Dr. Bajendra Basar Indore at Sri Aurobindo Institute of Medical Sciences. Presently working as assistant professor with Sri Guru Ram Das Institute of Medical Sciences, Amritsar, Punjab. Thank you, sir.
External camera. Focus.
I would like to invite the second
No, they will see it there, no?
chairperson for the
Just
live
show me
session,
that.
Dr. Vishnuswarup Reddy Garu.
Correct. मुझे लगा मैं हेडलाइट रखूंगा. इट्स अ ग्लास देयर. कैमरा एडजस्ट इट देयर. वो जो सीटी स्कैन है ना, एडजस्ट दैट. हेलो ऑडिटोरियम.
Yes.
हाय, आई एम वीरेंद्र हियर.
Yeah.
Okay. Is it possible for them to see a pre-op photo, or should I show it from?
Sir, I will show you, sir.
They have. Yeah, that's right. So maybe external camera can focus it here.
CT scan we are getting.
CT scan. Okay. Maybe a laptop or a. Can I magnify this? I'll just do it like this. Yeah. Okay. Okay.
Okay, we are getting.
You are getting a.
Yes, yes.
Okay. Just
Virendra,
paint something. Yeah.
there is some lesion on the right side of the nose now.
Yeah, that's right. That's right.
What is it?
No, it's just a small boil which is regressing.
Okay, okay.
So that's fine.
I
But
would
then
like
if
to
you
invite
can
Doc-
see, could be any instruments or a needle or just give me something.
Please describe the deformity.
Yeah, that's right. So, so if you see the face,
Yes.
face is divided into 1/3 part, 1/3 part, and 1/3.
Okay,
So the upper 1/3 is lower 1/3, and lower down the chin is not there. So, okay, but then it's pretty symmetrical. Here the hairline is not seen, but then at the picture in the OT it's symmetrical, and the face is divided horizontally into 5 parts. The distance between the medial canthus and the lateral canthus has to be same as the intercanthal distance, has to be same as your lobular. So you have to see any facial asymmetries, and then you will see the nose.
Okay.
Nose, you will see the bony deviation. There is a bony deviation on the right side.
Okay.
And you will see a cartilaginous part here, and there a cartilaginous deviation.
Okay.
So it's a C-shaped deviation also.
Okay.
There is a little bit bulge here, so I'm sure there will be uneven upper lateral cartilage. The
Okay.
tip is a little bit rotated down.
Is it bulbous?
Sorry?
Is it bulbous? No.
Yeah, little bit bulbosity is there. If you see the profile, there is a hump, but this is
Yes.
not the hump. This is a pseudo hump, because if you can see, there is the columella. If you see from top, the nasofrontal angles is good. The dorsum is good. You will see a hump here because our tip is gone down. So I will call this as a hump, but there is more of a pseudo hump. That's what I feel. If you go down, the tip is pointing downwards, it's rotated down. You will see the columnar show is not there. There is a retracted columella. There is no history of trauma per se, or there is no history of any surgeries. Sometimes you will see post-septoplasty deformity like this, as a that there is a collapse, there is a columnar retraction, the tip goes down, and that's a pseudo hump. But in this case, there is no history of trauma or no history of nasal surgery. As rightly expected, the tip is rotated on the left side, and you will see the uneven ala as well. Okay?
Yes.
And from a helicopter view, you can see a deviation, which is almost like a sharp deviation. That's a scan. I think we can focus it on a scan. The external camera, if they can focus on a scan, I'll explain a little bit. Now, this first case is little advanced, because we may have to. So now with a scan, in a deviated noses, you have to see any focus of infection in the sinuses. You will see the nasal septum, the cartilaginous part is sharply deviated, like this, S-shaped deviation.
Yes.
Oops, light. Okay. If you see the anterior spine, if you see the anterior spine is definitely rotated more than 40 degree. So you can see the spine is deviated in more than 40 degree. So maybe I will do a extracorporeal septoplasty for him.
Okay.
Because this deviation is looking really tough. The second case is much more simpler than this. So the first case is little tough for beginners to digest, but then the second case will compensate that. Okay, so we'll start with a little tough case today. The consent for, so what's my plan? My plan is a open septorhinoplasty. We'll open up, we'll take out the attachment of upper lateral cartilages from the septum, we'll expose the anterior spine, then we'll decide whether we can go away without doing a extracorporeal septoplasty. If there is a high deviation, we'll remove the entire septum out. What we require is a good spreader grafts. And if the good spreader grafts, in the sense the cartilage's deviation is too much, we are not able to find spreader grafts long enough from the nasal bones up to the anterior septal angle. We have taken a consent for costal cartilage. We'll harvest 10th rib mainly for a spreader graft for giving a good support. So let's see. So we'll open up the nose and then we'll figure it out whether we'll go for an extracorporeal septoplasty or not, which I feel we will we'll require that. We will see whether we'll require a costal cartilage for a good spreader grafts. That we'll see after opening. We are also going to try something new, which is a GoPro today. So let me check on my head. Chidanand is going to put a GoPro and we'll see. So then you can decide which picture is good, either VTOM, external camera or GoPro, and then accordingly you can decide and let us know, and then we'll show you these two views. If I feel little discomfort during surgery, I may shift to the VTOM and external camera. Right? So, any questions?
Hello.
Yeah.
Good morning, Virendra. Vishnu here. How are you?
Oh, good morning.
Welcome to Hyderabad.
Oh, thank you.
I was just showing exactly the same nose I did 2 days ago to Vishwas and Murthy.
Mm-hmm.
We're just showing the picture, exactly the same nose. Vishwas? So it's interesting. Good case actually. It's a very good case.
Yeah.
I think people will enjoy your excellent approach.
So.
Okay then. I did
So that
intranasal
means
actually.
Intranasal?
Yes.
Oh God.
I'll just show you the pictures when you come back to the auditorium.
I should come to you for learning. So, no, according to me, closed rhinoplasty is really tough.
Yes, yes.
And you really require a lot of skill to do it.
Right.
So,
thank you. We'll see you later on. It'll be wonderful to see your surgery. We've been interacting in our forum, FRCSI forum.
yeah.
I haven't seen your surgery. It'll be nice.
Yeah, yeah. So just give us a maybe 5-10 minutes to adjust all that, and then we'll start. Any comments from your side regarding the deformity or plan or?
I think it's quite a bad deformity actually. You know, the quite crooked, and I think we have to see how it goes. And Vishwas, anything to add? I think looking at the scan, it's very bad nose.
Yeah, that's right.
In that case, what I did, I have spent more time on septoplasty
That's right.
than the rhinoplasty.
Absolutely.
Yes, there are various ways of doing things. He's going to show external approach. I think with the internal approach also can be done, but it's a little tough, as he said. It's not easy. That's right. Else, Vishwas, will you want to add something?
Hi, Dr. Virendra.
Yeah, I'll do it. Yeah, that's right.
Dr. Virendra,
Yeah.
Vishwas here.
Yeah, hi Vishwas.
Yeah, you look like Robocop getting counted.
Anyway, I'm operating like robo only last few weeks.
No, hats off to you. Operating 7 cases, 7 rhinoplasties in a day.
So
Amazing.
What picture you are getting? Are you getting a?
The VTOM possible.
You are getting a VTOM.
Yeah.
Okay.
Now,
Yeah,
the deviations that you mentioned,
Yeah,
So there are two, right? One near the maxillary crest and the other at the K area.
it's perfect. It's perfect. It's good. It's good. No, no, it's okay. I'll do it without loop. Can you disconnect this? No? Hina, just a minute. I'll just go there. 1 minute. No, it's okay. I'll try without loop. Just disconnect this.
Hello?
Oh, no. Oh, sorry. Wait. I think it should not move. No, it's not gone. I'll just cross check it again. What thing you are saying is the nose. Yeah, perfect. Yeah, okay. It's not moved. Just remove this. Okay. I have to carry this.
The other image, is it the GoPro?
Yeah.
Hero
With
6?
the other image, or I'm not sure which
You're
image
getting
you are
both
saying.
VTOM and one from the
One is
lateral oblique.
the external camera, maybe.
External. Okay.
No, VTOM is on my head. So, no, I'm so sorry. The GoPro is on my head. Let me check. Okay, I'll just wash and come.
I think it's the first time we have so much advanced gadgetry.
Yeah.
Thanks to Dr. Chaitanya. He's done so much research there.
Yeah. And the same.
Chaitanya, Verendra, OT, anyone?
Hello.
Hello.
Yeah,
Can you little adjust the V term?
I'll do that. Yeah. Wait, from where I will go there? Wait, I will go from that side. Yeah. So. Something to clean? Gown or some towel? Yeah. Where is Shri? Where is Shri? Shri, wash and come. Yeah. Seven is fine. Oh, sorry. So how this is going? This is like. Sorry? Yeah, sure. Okay.
Verendra,
Yes.
do you use any hair trimmer?
Sorry?
Do you use any hair trimmer?
Yeah, it's Hina she's doing that. Hina. No. Hair trimmer, it's difficult to, this is a.
Blade, 15 blade.
So you can do it. This is little a better way. Trimmers are there, but then still it will keep few length, and then it's better to do it after you paint the nose.
Okay.
So to avoid an infection.
You have to do it the previous day.
Yeah, yeah. But then sometimes you get a small boils. So this patient has got already a little bit. Okay, चल हिना मैं कर लेता हूँ. So
One of the techniques for hair trimming is to get your angled scissors with some ointment smeared and then trim it straight so that the hair keeps sticking to the scissors.
Oh.
You can wipe it.
Yeah, that's right.
Any hair removing cream? No.
No, sir.
I use it regularly for ear, endoscopy ear.
Is it?
for
Any
your
French,
chest.
yes, routinely for all ear surgeries. Because for endoscopy ear surgeries. I learned it from Dr. Mohan Reddy of Hyderabad.
Oh, nice. What cream is that?
This is wheat, any French.
Need to ask the
You
ladies.
have to take it in a syringe and put it in the ear canal for 5 minutes, then wipe it out.
You can put a light on a light
A nice
source
idea, sir.
cable
We'll
there,
try it next time.
because we are getting a less light. I don't have a headlight on top. Are you getting a picture?
Yes, Virendra, we can see very well.
Which picture you are getting?
Okay, I think two are there. One is a full nose, we can see. Other one is a half nose.
Acha, okay. So maybe a VTOM.
VTOM you have to adjust.
VTOM I have to adjust.
Hello, sir. I'm Dr. Jaskaran. How are you, sir?
Wait a minute, we'll just use a GoPro first. We'll just get a GoPro image. So just give me a 1 minute. Yeah, just pack it. Pack it with adrenaline, then we'll just pack it. Yeah, yeah. एड्रेनलिन है उसमें just give me a little bigger one. It's there. Yeah. Okay. Sure. Looks good. I hope this GoPro works, and yeah, okay. So I'm focusing on the nose. Is it focused on the nose?
Hello.
Just, I think we should adjust that.
We are having two pictures. One
Yeah.
is showing the basal view.
Is it moving? Your picture is moving now?
No,
No. Okay.
it's gone. One is gone. The other one is moving, but that is focused on the left eye.
Okay. Okay. That's a VTOM. Wait. So I'm seeing at the tip. I'm seeing at the tip of the nose. So I
But
just
we are seeing the
adjust.
left eye.
No. This is to Chidanand. Chaitanya nahi. Chaitanya. Yeah, wait. Yeah, I'm focusing at the tip. Yeah. Yeah? Clear? Yeah. Are you seeing?
We have only one picture, and that
Okay.
is showing the left eye.
Okay, okay. Just let me know once you get a second picture. So then we'll start. That will be our GoPro. Hina, meanwhile, just adjust VTOM. थोड़ा सा left पे है ना? Yeah. Is it okay now for you that it's not sterile? Oh, sorry. Are you getting an image now?
No, sir. Actually,
The
it's very
second-
skewed. We are only seeing your left three fingers.
Left 3 fingers. Acha.
Only
So
that is visible.
now?
Right now, we are seeing the tip of the nose.
Okay, okay. Is it adjust focused here?
It's slightly skewed such that the nasion is at 1 o'clock, I think.
Okay.
The other camera is showing the nose in a horizontal position.
So that's a GoPro now. So what is it moving now? Is it
Yeah,
is
is
it on
moving,
the
it is
trolley
moving,
now?
It is moving.
Yeah, okay. So that's a GoPro now. Okay, so that's a exact view what I am seeing. Okay?
No, now it has become inverted.
Inverted.
Okay, now okay.
Now okay?
Yeah, fine.
Hello, Verendra sir. Dr. Jaskaran here.
Yeah, hi.
Hi, sir. Sir, can you show the external fixation of GoPro on your head, how it is fixed?
Yeah. The external camera can show us. You are not getting. Okay, I'll show you soon.
Sir, let us finish the experimentation. Last we can show that.
Yeah, that's right. Give me Aller retractor. So is it okay for you in GoPro or it's
This Whitcomb is
Whitcomb is better?
That is far better.
far better? So then we will shift from GoPro to VTOM and then headlight. Okay. ठीक है. So just give me just 2 minutes and then we'll restart. Right? Okay. ये निकाल के headlight and ये कर देंगे. ये निकाल दो. But GoPro is something which will come now. So yeah. That's a VTOM. Remove the headlight also. Give me my headlight. Where is my headlight? Yeah. उसमें बैटरी लगा देना पीछे. वो बैटरी नीचे चार्जिंग का है. वो एक बैटरी लगा के दे देना. ये I'll remove this. I'll remove the bag. Just hold the bag. Yeah. Okay. That VTOM picture is good?
Why? That VCOM is good, sir.
VTOM is good. Okay.
Vitamin is good, but little turned to the left. Can you make it exact vertical?
Yeah.
The angle.
The angle?
Yes. That's fine. But we are not seeing
Okay.
the nation. Yes. That,
Yeah.
now it's perfect.
Now it's perfect. Okay.
Okay.
Good. Pura open it and then put it.
So you prefer loops or you prefer to do without
I'll-
loops, sir?
No, with loop. No, this is okay. This is okay. So, no, I have a loop here. Yeah. Okay. Fine then. So I'm back to the original one. So we'll start it. Can I get a methylene blue or any marker? So this is a lower border of lower alar cartilage. So I will start with a marginal incision first. Anytime, just let me know if there is some problem or it's not seen, out of focus, or if I am not clear. So again on the left side, this is the, you can see that's a lower border of lower alar cartilage. So key here is just 3 millimeters behind the rim, and key here is to avoid an injury to soft triangle. Now the alar incision I have gone down, very down till the base. The reason for this is during suturing of columellar strut, my knot should go inside. I will come back to this point again. So there are two ways of doing it. One is a dissection from lateral to medial like this. So I'm elevating the skin envelope from the cartilage, and then I'm going to take an inverted V incision. The other method is you take an inverted incision first and then you retract. Ultimately, it does not make much difference. It's just a matter of your the way you have learned.
Virendra,
Yeah.
that identifying that border of the lower lateral cartilage, lateral crus.
Yeah.
I think that's the key when you.
Yeah, that's
if you
right.
can-
Yeah, that's right.
If you can identify, then just go over there.
Over it and then
That's right.
just
Yeah.
that's right.
That's the good point for juniors. If you identify the lower border of the lateral crus, then it makes your life easy.
Yeah, you can see it here. Sure. Wash. So with this step, I feel for beginners, because the commonest complication is injury to the lower alar cartilages. With this technique, I feel injury is less, because if the skin is really thin, then your incision is going to give you a little bit of a trauma to the lower edge of the lower lateral cartilage. So this will avoid it. What will happen if you injure it? If it is partially cut, just take a 6-0 Proline or a PDS and then just suture it. If it is a complete one, then maybe you have to little bit reconstruct. Okay.
Virendra,
So, yeah.
the infiltration is ropivacaine.
Yeah, the infiltration is ropivacaine,
Percentage?
0.2%, and 10 drops of adrenaline
For how many ml?
in 20 cc. So that's the narrowest portion of columella. Somewhere here. And then I will take an inverted V incision. It's not working. Pen nahi hai apne paas. So this is the one. That's an inverted V here. Generally it's 3 millimeters. No, still 11 number blade. Wash kar le, please.
What are the points you infiltrate before starting?
Yeah. So infiltration is for two purposes. First is to elevate all the planes, and the second one is for vasoconstriction effect. And the third one may be a post-op pain management. So you infiltrate on the point of columella and at the level of the incision. Then you infiltrate on the dorsum and on the ala for our skin envelope dissection.
And also, I don't know how many of you have observed, he's been using 11 blade for the incision. That is very, so better off with 11 blade to make that incision, isn't it?
Yeah, that's right. It's really sharp.
Yes.
And
Not the 15 one.
it's not the 15, it's more precise. Give me bipolar, please.
There's a lot of soft tissue over the cartilages.
Yeah, that's right. We have seen the tip is bulbous, was bulbous, and we expect a lot of fibrous tissue there. Little bit oozer here, bipolar pad, it's there. Yeah, show me. Bipolar, it's not working. Now should I try? No? No? Okay.
Hello,
Hello, C-shape retractor.
Dr. Virendra.
Yeah?
Are you in supraperichondrial plane?
Yeah, that's right. So I'll go to subperiosteal. So here is the dorsum. Yeah, can you see it?
Okay.
Yeah, and then I will cut it here. Yeah. So that's a plane of which yeah. Just tell me once bipolar is on. Ghaisvas, so keep a Ghaisvas here, please.
Dr. Virendra,
Yeah?
we were just discussing here, there's a furuncle on the
Yeah, that's right.
this one. Is it any contraindication for your surgery,
Yeah.
or would you really
I would have
not bother?
postpone it.
You would have postponed.
Yeah.
What would be the reason?
We don't want any infection to go on the dorsum. If we have done some kind of augmentation there,
Right.
but then what I did was I just pressed that and I just saw it's not infected. It's just a small cyst there.
Okay.
So
So you mean to say any free graft, there should be hardly any infection?
yeah, that's right. So wait, I'll just okay.
One more point. If you insert any implant,
Sorry?
if you put any implant, again it's a chance you may get.
Yeah, that's right. I don't put any implants. But then yeah, so the message has to be very clear. So
Do you combine minimal face surgeries along with rhinoplasty?
yeah, we can. So I'm taking a incision, a midline incision at the periosteum and at perichondrium. So I will be elevating a perichondrium or a periosteum and periosteum laterally. So that any kind of a graft or any kind of a will be on directly on the bare bone. Yeah, I think it stopped till then, but then still. Yeah. So after elevating a perichondrium, I am elevating a periosteum from the upper lateral. Can you see the upper lateral clearly on the right side?
Yes, it's quite clear.
Yeah, okay. And then I will do it on the left side as well. See, this is important if I am going for either hand there, please. A spreader flaps. Okay, so the next step is taking care of soft tissue on the lower lateral cartilage.
Does this patient needs symmetrical alert strips?
Yeah, that's right. If you have seen a preoperative photo,
Yes, sir.
there is definitely unevenness. The most difficult nose, I will label it as a post-cleft nose. The second one is deviated nose like this. So just keep preserve everything whatever I remove. Because in deviated noses, everything will be asymmetrical. A facial asymmetry, The nasal bones will be asymmetrical. The upper lateral, lower lateral cartilage will be asymmetrical. And down ala, septum, sometimes the anterior nasal spine also, the positioning also. So everything will be asymmetrical. So definitely deviated noses or the crooked noses are tough to operate.
Agree with you, Dr. Verendra, because the ones with the gross deviated external deformities, they have facial asymmetry as well.
Yeah, that's right.
Unless we make the patient aware pre-operatively, they're going to come back and say, doctor, this part also needed correction, or
That's
possibly
right.
they'll say, I have a longer dorsum on one side because the sloping is too much.
That's
So
right.
they need to be made aware, or if we have a record of the pre-op photos, show them and tell this is also a problem with the face.
So I have taken a interdermal incision and will go towards the septum.
You're so elegant with the scissors in that area, you would probably slow down a little. You're going so quickly.
Okay, okay. Let me know, yeah. So you have to just feel a caudal border of septum, which is somewhere here. So any small tear here in a vestibular skin. So we were talking about the infiltration. The important part is to infiltrate this vestibular skin, this
Right.
skin.
Yes.
Yeah? So once it is elevated, it becomes easy to dissect it. Any small tear here is, according to me, is fine, but then there should not be any kind of a skin loss there.
Yes,
So a small tear is fine.
we'll accept it.
Yeah,
So if it happens, you would close it with Vicryl
yeah,
Rapid?
yeah, that's right, that's right. You can close it. So let me know if my picture is not centralized or not.
It is central.
Yeah.
It's fine. So this technique of irrigating with saline to clear the blood and the clots, it's a nice technique. I have picked it up now.
Yeah.
Finding my dissections much more easier.
Much more easy, yeah, that's right. So that's a caudal border of septum, and very important structure here will come as depressor septi muscle, because this will always pull this cartilage down and it will deviate the septum.
Yes.
So we will dissect it. It's not visible right now.
So during the pre-operative photograph,
Yeah.
do you take a patient's photo with the smile to
Yeah,
see the
that's
depressor
right.
septi in
That's
action?
right, that's right.
Okay. Generally, it is instructed to us to take it in neutral, but we miss the smile.
Yeah. So you can see I have dissected here, and so that's a plane. Yeah. Can you see appreciate the plane now?
Yes, yes. yes.
That's anterior superior septal angle.
See, hello.
Yeah?
Yeah, that's very important. That plane, I think, I'm sure all of you know that plane. I think when you
Yeah,
are doing
so-
septoplasty, once you are in that plane, that makes your life easy.
That's right.
Dissection will be easier and there won't be any bleeding.
Even if you have preserved a perichondrium nicely, the chances of septal perforation post-operative in period are less.
That's why good infiltration it helps
that's right.
very well there
That's right.
for this dissection.
So here I will be little bit slow.
Do you want to elevate the flap on either side?
Yeah, from both the sides.
So which side you want to elevate first, like if there is a deviation?
No, does not make any difference.
Okay. Usually when there is a deviation, I prefer better to elevate on the concave side.
Yeah, the soft tissue is little less and it's easy to do it. No, but it's okay, sir.
I think you can preserve the flap in one side because you are seeing the flap on entire flap you are seeing.
Yeah. I'll require 0-degree endoscope as well.
What he was mentioning earlier,
Yeah, we'll do it later. Yeah.
a pseudo hump, that's also very, very important thing.
Yeah.
Here, once you elevate, you may not find the septum. If suppose there is any previous surgery done. In this case, of course, there is no previous surgery. Otherwise,
right.
pseudo hump also can present like that.
Absolutely.
The deformity.
Absolutely. Very true. So, just give me a wash first. So either you can do this with a knife, I do it with the tip of a scissor. Yeah, that's a plane. And sure, give me specula. Still the deviation is really bad on this side. Yeah. So at least what we have done here is we have intact flap on the left side. So even then there is a small tear here. It's fine. Kya? Nahi, baat. Thoda baat. Yeah, elevate one. Yeah. No, once I elevate this, I will require it. Layer on top. Yeah. So what here, there is absolutely a 90-degree deviation here. So it's difficult to elevate a mucosa on the posteriorly. So what I will do it here is I will cut attachment of upper lateral cartilage first, and then I will do it. So I'm just elevating a mucosa superiorly. So is it visible now? The attachment of upper lateral cartilage. So, and with 11 number blade. So there is a deviation here. Okay, so similarly on the left side. It's absolutely a 90-degree deviation. Give me Caesar. I have a Caesar. Take this. Yeah. Can you see the elevation now on the opposite side?
Yes.
Yeah. Okay, so from here, from on top, I went back and then I could elevate mucoperichondral flap posterior to this sharp deviation.
Yes, yes, beautiful.
Is it okay?
Now you're going to bring whole septum outside?
Let me check. So this is the time where when you divide it, the depressor septum muscle, and I think I will show you the nasal cavity before it with 0 degree, and then I will do it. So suction, simple suction, nasal section. Yeah, can you see it? It's a very gross deviation.
Yes, yes.
Yeah, and we cannot pass endoscope from here. And put a speculum. Speculum, did it?
The scope is a bit fog.
Yeah, I will do that. So, Ina. So, clean it. Wash, please. Little tight, yeah.
Take it.
Focus करो थोड़ा. Yeah. Yeah, you can see a severe buckling here.
Correct.
Yeah. That's a maxillary crest down.
Yes.
And from here, so wait a minute. Yeah. I have elevated on the opposite side as well. Yeah?
Okay.
I think my sound has gone. Nikal.
No. We are able to hear you.
Hello?
We are able to hear you.
Hello? Yeah, I think battery of that is gone. Okay, just apply it here. नहीं ये लगा देना please.
Dr. Chaitanya.
Keep it. Hello?
Sir, you are very clearly audible.
Yeah. Okay. So, now, another thing remaining is I will dissect the septum from the floor. So ultimately I am dissecting except for breaking the bony cartilaginous junction posteriorly. Superiorly I have removed the attachment of upper lateral cartilage. Anteriorly I have removed the attachment of depressor septi muscle. And inferiorly now I will just elevate from a maxillary crest. Elevator. Now after releasing all three parts, all three sides, then we'll decide whether we have to do extracorporeal septoplasty or with a simple SMR like a stuff.
Dr. Verendra?
Yeah?
So, what are in your hands, what's the results of morselization? We bring out the septum and then make it straight and then place it back.
Yeah, the extracorporeal septoplasty. Yeah, the results are excellent. So, it's a little tough procedure, but the results are perfect. So, and it's done only in deviated, extremely deviated noses, like this. Let me check. From the floor, it's not yet dislocated. Yeah, from floor it's dislocated now. So now what I will do is, I'll just hold it in a finger and I will try to mobilize it from a floor. Yeah.
It is by
Yeah,
feel.
It's feel. Yeah, it's feel. But then
From
it's
the
getting
maxillary
fractured
crest,
and
just-
cut. Yeah, no. Yeah. Okay. So, take a C-shaped retractor.
Dr. Virender,
Yeah,
can I ask you a question?
sure, sure.
Now, at the maximum convexity that we had, that angulation,
Yeah.
can we actually split it and then go ahead?
Yeah, that you can do it. That is some split it and then fix it again.
Correct.
Yeah. So this is a partial extracorporeal, you can say, block. That will be little bit half altered.
One announcement for the delegates. Tea, coffee are available outside and biscuits. Please have it there. But they are not allowed inside the hall.
See the whole. So now you can see there was a gross deviation. Okay. What we did was we just gave us this septum, the cartilageous septum, a space to expand, right?
Okay.
And it has expanded antero-posteriorly. Okay. It has come out from the medial crus. Okay.
Okay.
The moment it has got a space to expand, it has become straight. Can you see it?
Yeah.
Yeah. So I'm not going to remove the entire septum. So I won't do an extracorporeal septoplasty here.
Okay.
Okay. So I'll keep this K junction intact, and then so we'll do a septoplasty. Then we can do the tongue in groove later, and so it will be a pretty straightforward, simple.
How will you manage the high deviation?
Yeah, we can trim it. So now you can see the high deviation will make it straight with a spreader grafts. Now the septum has grown, it has expanded antero-posteriorly. Similarly, it has gone up also.
Okay.
Okay, and this will take care of your pseudo hump as well.
Okay.
Yeah, can we see it from side camera, external camera? Can you show it from here?
Yes.
So basically, you're reorienting the septum.
Yeah,
to
that's
its
right.
natural position.
That's right. So are you getting an external picture?
Yeah,
The
we
external
get this.
camera picture?
Yes, yes.
Yeah, okay. So first of all, it was deviated down. The septum was deviated down. Okay, are you seeing it? Wait,
Yes,
I
yes.
think my hand is coming in a way. Okay, so the septum was down and deviated like this. So from profile, you can see the tip was down and it was looking like a pseudo hump. It was looking like a hump. Okay?
Right.
The moment I have made my septum straight,
Yes.
yeah, that hump is gone.
Yes. Beautiful.
Yeah, so this was a pseudo hump. So this was a pseudo hump.
Okay. Okay.
Okay. Now, if my septum is still on the little on the higher side, you will get a polybeak that definitely will treat it. But at least we are not going to remove this hump because this was a pseudo hump. So in this case, what was the root cause for all this deformity was an external deviation of the septum and which has gone in, right? So what you have to do is a good septoplasty, make the septum straight and let the septum stand straight, and rest everything will fall on its place. Okay?
Yeah. So is that the reason you didn't split up to the K area to see
Yeah,
whether
that's
it's pseudo
right.
hump and
That's right. That's right. So now I won't do extracorporeal. So we'll just remove. We'll just keep a L 1 centimeter L, and then we'll take care of a maxillary crest as well. So what a pair say? 15 number blade. So with V-tom थोड़ा सा टेढ़ा करके दिखाएंगे. Yeah. Okay. Okay. So you can see that's anterior septal angle, anterior superior septal angle. That was the inferior one. I'll go behind. I'll keep approximately 1 centimeter.
How will you decide the width of the L strut?
1 centimeter.
Now, how will you decide, like, if strength of the cartilage is not so good?
No, still 1 centimeter. If the strength is not good, then you can give a strength either with a spreader graft. You can splint the cartilage with the ethmoid plates, that I will show you in this case, because there is little bit deviation. I will show you that.
Okay.
So you can splint that cartilage. Wait a minute, the towel has gone down, so थोड़ा अच्छी तरह लगा देना please.
Sorry,
Yeah.
what is this?
Look the L strut,
Yeah.
Right. Width and-
1 centimeter.
Yes.
Why not 0.5 centimeter?
The 0.5 is not enough to maintain the,
2 centimeter.
if it is thick, you may get away, but still 1 centimeter is ideal.
Sorry? बाद में देख
There is no
लेंगे.
hard and fast rule. Right.
So ultimately we will keep 1 centimeter of L-shape cartilageous septum behind. So now I will break a bony cartilageous junction. Give me elevator.
You have not given sharp angulation at the L strut.
Sorry, sir.
So you have not given sharp angulation in the L strut. I can make out.
Yeah, the here.
Yeah, that's
Yeah,
all.
yeah,
So what is the reason?
It's little smooth. Yeah, there is a lot of talk on it. The survival of the cartilage. Previously, I used to do it with a sharp edge. And then it was Professor Gubish who made me to change suction elevator. Laga dena, please. Maybe the survival. So, just a minute, sir. I'll just wait for a suction elevator. Yeah. ये मत देना यार. So, अभी तो था पहले.
If the audience has any question to ask, please feel free. I think no question is bad.
Yeah. Especially great, big shots in the auditorium they are sitting, and Vishwas, Dr. Reddy, and they are so good with the subject. So I think delegates should ask questions and make the best out of it, because they can answer it so well in a meticulous manner.
Thanks for the compliments, Dr.
Hey,
Virendra.
come on. Yeah, Vishwas.
I think
you are too good.
No. I think the fame of the rhinoplasty has seen a new era thanks to Dr. Vishnu, you, and all the seniors. Now, extracorporeal septoplasty is something that we didn't believe in initially. So it was partial what we used to do. Thanks to your thinking and demonstrations, we have all picked up extracorporeal septoplasty, and so many of your techniques, the ethmoidal bone, the way you drill it and put it as a batten. In fact, the evolution from the older techniques to the new techniques has happened in the past 5 to 6 years. I am sure you have a big hand in that.
Which, sir? Gubish.
Your hand.
Acha, calling me sir, huh?
The same cartilage you can use for augmentation, what he has harvested.
Yeah. So we have harvested that L-shaped cartilage, from which we'll use a spreader graft, and we will also do a free dice cartilaging, and we'll take care of the irregularity on the dorsum. Give me lux, please. There is a little bit of a bony deviation at the level of vomer, which I will use it. If there is some deviation at the model plate, we use a Caesar and then trim, and then we do it with a lux. So, like down.
What's your advice to youngsters or postgraduates who want to do a septoplasty for such an external deviated nose?
Yeah.
What would you tell them? They're not still trained in rhinoplasty, so what do they do with the patients?
Open it.
Open it. So
Open
they better learn
septoplasty.
the
Start doing
rhinoplasty.
open septoplasty. Yeah.
Okay.
So with a Caesar, with a Caesar, I have just trimmed the ethmoidal plate. See, because if you remove the, the ethmoidal plate with a lux, then sometimes you can get a fracture line in a haphazard way.
Right.
So it's better to cut it and then remove it with a forceps.
That's very, very important. Actually, there are reports of CSF leaks by forcibly avulsing the ethmoid plate. And also, you have to maintain the bony cartilaginous septum. You should not disconnect there. That can also cause some deformity, step deformity like.
Very true.
So very, very important step, cutting. We always use, my sister always gets upset because the scissors getting blunt.
No, we have a special Caesar.
Right.
What Caesar is that? We did notice that. Looked like a K-wire cutter.
Yeah, something like that.
Yeah.
This is a Karl Stoss.
Yeah.
That VTOM is also there. In that Medicon is also there. I will show you that other Caesar.
Okay.
So
I think that's a good scissors we should buy. My turbinectomy scissors are all getting spoiled.
yeah. So you should use this like a strong Caesar. So I'll show you the Medicon Caesar as well, and it's so good.
Because sometimes the bone is very tough to cut.
Yeah, that's right. Oh, sorry.
Scissor looks like a wire cutter used by dentist.
Now there is quite a big, you can see a maxillary crest. Yeah. So that's a Caesar. Yeah, it has got a serrated edges. It's a big one. It has got a curvature.
Angled.
Yeah, it has got angle.
Double action?
Yeah, double punch. Yeah, double punch. 1 and 2. Yeah.
What is the name of it, Virendra?
Garam diya.
Any name for that, Virendra?
Name, Hina knows it. Huh? Kaplan.
Kaplan. Okay.
I think half of our expenditure goes into the instrumentation itself.
That's right. This Caesar cost from Medicon at least 50,000. But then the best part is I'm using this Caesar since almost 10 years and I have not changed it. So that's an anterior spine. That's an anterior maxillary spine which I will keep it. It's in center. I will go a little behind. Wait, let me check it first. Yeah. And then 5 millimeters behind, and then I'll remove the maxillary crest.
Why you are leaving 5 millimeters of spine anteriorly, sir?
Yeah, because we want to keep the anterior maxillary spine intact. If you remove it, then again the support to the anterior septal septum will go off. And again that pseudo harm, this, that, same thing will happen. Nahi, elevate nahi hua hai. So yeah, that's a maxillary crest. Okay, just remove this. Give me a mop. Yeah.
A warm saline or sir?
It's a cold saline. So what I'm doing here is I'm just cutting a soft tissue anterior to the anterior maxillary spine. Yeah, so I've given a space for this septum to grow. So first the septum was attached to a spine. Okay. Now the septum will be fixed anterior to the spine. Give me pack. Give me 0° also.
You going to drill any hole in the remaining spine to fix the septum, sir?
Sorry?
Are you going to drill a hole in a remaining spine so that to fix the cartilage septum
Your
there, sir?
sound is little
No, do
less.
you want to make a hole in the anterior nasal spine?
No, because we are keeping this anterior to the spine. We are not on the spine. So if you are, give me lux please. If we are keeping it, if you are drilling the spine and suturing, again there will be a deviation because our septum length is more.
Okay.
You got my point? I'll show you. I will demonstrate and show you. Suction dena please. Yeah. Wait a minute.
Have you come across any intractable bleeding
Yeah,
when you?
especially posterior inferiorly. Yeah, twice.
How will you manage, like how to
With
control
a
bleeding?
diamond burr, because the give me a packing small forceps than a lux. There is small bony chip which has going behind. Sorry, sir. Yeah, interactive bleeding from posterior inferior, the septal branch there,
Okay.
especially in extracorporeal septoplasty. And so no, with a diamond burr, you just do it. That artery, the entria, and then it will stop. You can put a bone wax also there,
Okay.
and it will stop. Otherwise, from septum, except for posterior inferior part, there are no big bleeding points there. So now towards the maxillary crest, there is a small tear, a linear tear, which again I am not much bothered about it. Give me another pack. Again here also a small linear tear or a long linear tear won't give you any kind of a problem. Again a mucosal loss. So while removing the bone or while removing a septum, if the mucosa comes along with that, so if there is a mucosal loss there, then there is a problem. So a linear tear you can approximate, you can suture it, but if the mucosal loss is there, then there is a big problem. So you have seen, you have seen a big deviation on the right side. So give me wash please. Sorry, under a orec packer. Wait. Give me suction. There. So can you see that entire deviation is gone? You can see a middle turbinate. Yeah?
Yeah, we can see.
Oops, sorry. That flap comes under with my suction, and then there is a linear tear here. Okay?
Only
But the
one side.
opposite side, the opposite side flap is intact. So I'm not worried. I'll show you here. So it's here, and there has to be a small, you can see a pack from outside. So there is small tear here which will suture it down. Okay? That mucosa here. So there should not be any problem. So on the opposite side, we'll see. So it's better to see packing forceps to deti. Okay. With an endoscope always, because posterior perforations, small tears here and there. So you can see a small tear which we have seen from the other side. And I don't think so there is much problem here, but still. Okay. So except for that small, where that went, okay, small part here. So with 50 Vicryl, definitely while suturing I will suture. So if there is a linear cut here, don't bother much, you can just suture it here. Yeah, so it's easy, very easy to suture. But if there is a mucosal loss, if that entire flap comes out, then there is a huge problem. So not much bothered
The
about
delegates asking,
Will you
Yeah.
be able to show us how to suture?
Yeah, of course I will show you.
Yeah, thank you.
So maybe a good endoscopic surgeon than me can show you with a one. So I do it with
Okay. If it is endoscopic, it's okay, no problem.
no. Yeah,
I do that with endoscopically. I thought you will do it without the endoscope.
I will do it without endoscope
Okay.
because I am not very good with endoscope. Okay, so this part is the main key which we have to suture. And then, okay, that's a septal flap. Okay, it's intact, not a problem. Okay, so small linear cuts, it's absolutely fine, don't bother much, just suture them, you will be all right. Mucosal loss, you should not go for it, then you will mess. Okay. Now you have to focus it on the dorsum. ये थोड़ा आगे लेके आ जाना. You fix it. I will do it. V-term angle we have to change now. ये थोड़ा आगे लेके आओ. Yes. Yeah. थोड़ा ऊपर उठाए तो भी चलेगा because that's too magnified. Okay, the next step now is osteotomy of which 5 mm osteotome of which देना of which retractor बड़ा वाला retractor ये ना प्यार से आराम से किधर गया of which got it here. क्या हुआ इट जस्ट केम ऑफ अरे वो लॉक है वो ओपन है इधर से लॉक है लॉक इज ऑन द ऑपोजिट या फिक्स कर लेना प्रॉपरली या ओके so that's a 5 mm osteotome wait I'll just wait yeah that's a 5 mm osteotome yeah is it seen now
yeah, it is.
yeah okay so that's a 5 mm osteotome. So one side is straight, which will focus towards the septum. So it's a paramedian osteotomy. So give me methylene blue.
Oh, now you are marking.
Yeah, I'll just mark it. Generally, I will just do it like that.
So no need
Zoom
of dorsal reduction.
No, sir. So we'll do it after fixing everything, not now. Because
the osteotomies you have planned in this patient?
So I will go for a paramedian osteotomy.
Yes.
And I will go with low to low lateral osteotomy. So that's our pyriform aperture.
And transverse?
Yeah. So that's our pyriform aperture here. So that's our lateral osteotomy, low to low, and that's our transverse osteotomy.
So
When
when
you
do we
decide-
decide? I think both of us have the same doubt.
Yeah.
When do we decide it's low to low and when do we decide it's
I
high to
will
low?
always do low to low osteotomy. I will never do low to high and then break somewhere in between. I won't go for it. I'll always do low to low osteotomy.
When do you start high to low?
High means we have to start from here.
Correct.
So why you want to do that? To give a step deformity. So I'll always do low to low osteotomy. Now here what will happen now, there is another intermediate osteotomy also. Okay. Now what happens is there is a deviation like this. You can see on external camera, maybe a deviation like this. Okay. The bone is deviated like this. After doing osteotomy, that this is the deviated part.
No, we are not seeing it yet.
Are you seeing my hands?
Now, yeah.
Yeah, okay. So it's a nasal bone which is deviated on the right side. Okay. Now the left nasal bone, the width is more. Okay. Once I do a osteotomy and make that part straight, my left side nasal bones will be at the higher level
Okay.
as compared to the right side. Okay. So there are two ways to correct that. One is you do a intermediate osteotomy. You do low to low osteotomy,
Okay.
and then you do intermediate osteotomy. So while that there will be two layers, and then while suturing it after osteotomy, it will go down and then it will be of the same height.
Okay.
Okay. Now osteotomy itself is a blind procedure. So again adding a third osteotomy, intermediate osteotomy, again, another a blind thing which I don't like. So what I do is after the height of one nasal bone is more, you just trim with this scissor, the upper end,
Okay.
and make them symmetrical. Okay. So
understood.
I will always do a low to low osteotomy.
By
And here also what you have to see is a convexity and concavity of the nasal bones. So here I can see a little bit convex, but this is not a convex. So I won't do a diamond drilling. Otherwise, I would have made this nasal bone flat with a diamond burr. 5 mm osteotomy. Yeah.
By intermediate osteotomy, you mean
yes.
double level nasal osteotomy, sir?
So that's upper lateral cartilage.
The another
Wash
important
करके
point
दिखाना
here,
पहले. Is it
whenever
visible?
you are planning for an intermediate osteotomy, you should do it before doing the lateral osteotomy. Virendra, hello,
Hello.
hello.
Audio. Audio is not.
Hello.
Yeah.
Hello. Hello.
Okay.
Hello.
Do it.
Hello.
So I will do it till at the level of medial canthus.
Can you hear me? Hello.
Okay. Suction, please. Can you see the osteotomy side? Is it
Hello.
visible? Yeah. Okay. Now I will do it on the opposite side.
Hello. Hello. Hello.
Hmm.
Hello.
Dr. Virendra?
Hmm. Okay. Now with the external camera you can show rather than VTOM is I will do a
Hello?
external lateral osteotomy.
Can you hear me?
Hello.
So I am going to take a small nick midway between the medial canthus and the lobule at the nasofacial groove.
Hello.
So for discussion
Hello?
purpose, there are two types of osteotomies. One is internal and one is external. Internal is the one which you will go intranasally, taking a small incision at the anterior part of the inferior turbinate. The external osteotomy is through these small nicks. The marks here are not seen at all later on. So don't get scared with that. So I'm just elevating with the one side of the osteotome. I am just elevating a periosteum so that the angular vein here will drop down and the chances of bleeding are less.
3 millimeter. The 3 millimeter osteotome.
Okay. So I'm exactly at the nasofacial groove.
Hello.
Hello.
Hello. Yeah.
Yeah. Actually, we lost audio.
Yeah. So okay.
Sir, aren't you very close to the medial canthus?
Yes. I'm little anterior to the medial canthus. I don't want a step deformity to happen there. But the medial canthal ligament is much more down. The lacrimal sac is far down. So
Is it 2 millimeter or 3 millimeter?
it's a 3
osteotomy?
millimeter.
Okay.
I'm surprised Ayla is awake and in the auditorium. So, yeah. I'm really happy Ayla is going for rhinoplasty.
Hey, Virendra,
Verendra,
Vishnu here.
Yeah.
You are planning for an intermediate osteotomy, isn't
No,
it?
I'm
you're
not.
Okay.
I'm not.
If at all, you have to do before doing the lateral osteotomy.
Yeah, that's right.
Verendra,
Yeah.
I attended that John Ram course. You came and
Yes,
did.
of course, I remember that.
After that, I copied that in hard disk and watched your surgery 25 times in 10 days.
Oh, God.
Then I did my first rhinoplasty very successfully.
Oh,
Thank you.
thanks, man. So,
Virendra, you have to ask consultation.
sorry?
Surgeon's fee.
Surgeon.
Please, because he copied.
No.
Okay.
No. Guru Dakshina, ask for his right thumb.
Yeah, Guru Dakshina. Complete. Whatever he charged the patient, he has to send you.
No, he has to give him his right thumb.
Yeah.
My rhinoplasty mentor. I'll finish it with that.
Yeah. So I'm sure Mubarak will be happy if I take right thumb of him, Ayla, because then so that 100, 200 fight will go off, and then Ayla has to do it with a stand. No, but for
Ayla,
juniors, it's a good thing that
Viren.
seeing videos. Yes, sir.
He is dangerous for Ahila.
Yeah.
Even he doesn't have the thumb, he will use something else to operate. Nobody can stop.
Yeah, with Ayla, anything is possible. Huh? So, okay. So, can you see the straight septum now? Should I zoom
Yes,
out a
yes,
little bit? थोड़ा ऊपर लेके जाना. So, yeah. Now fix it. Now focus it. So. So you have to trim little bit of a cartilage here.
Yes.
Yeah? So you have to trim little bit of a cartilage here.
That's right.
But now you can see absolutely a straight septum, a straight dorsum. Yeah? So, yeah. Maybe an external camera can show from somewhere. आप थोड़ा सा आगे इधर से दिखा सकते हैं because और make it और from the side इधर से दिखा सकते हैं sky view दिखाना है Can you show us a sky view from here एक trolley side में लेके जाना Give me a fresh Ghaisvas. It's okay. Because osteotomy is the main thing, so which will see there are two parts of a failed or a revision septorhinoplasty. Are exactly center में आओ ना? Center, exact center. So now that septum we have to fix it here. Are you getting an external camera picture now? Hello?
Yeah,
we are getting the picture.
Okay. So, is it visible now?
Yeah, it is visible.
Yeah. So it's a straight one, except for a little bump here, which we'll see. But otherwise, that deviation is gone now.
Your external picture is showing from the head end.
Yeah, from head end only.
Oh,
yeah,
fine.
sky view, because that will show you the exact whether there is a still deviation or not.
Actually, not the sky view. We have to angulate the camera.
Little bit angulation. Bring it down. थोड़ा नीचे लाओ. Camera नीचे लाओ. Stand tripod नीचे करो. Bring it down. Okay. I'll just give me a forceps. Just tell me if it is looking deviated or not. So,
What about transverse osteotomy? Want
we
to
did
do
it. I did it.
by finger.
Yeah, yeah. I think I should have done a little slower. So, is it seen now?
Yes, we can see very well,
Yeah?
Verendra. I think now the picture has gone out of focus.
Yeah,
Now.
he's just
Yeah.
adjusting a little bit. So,
And except for the small little.
yeah, that little bit
bump
of
is there.
because there was this hump.
Yeah, yeah.
So that the upper lateral cartilage is little thickened here, which
Right.
will trim.
Can trim always.
Yeah, is it seen now?
Yeah, as long as there is no bony hump.
Yeah.
So you're okay, I think. Yeah,
So
it looks straight.
Looks good.
Yeah.
Looks straight.
Yes.
Yeah. Okay. Yeah. Fine. Now you can come down. Perfect. Okay. So now the remaining part is हो गया. अभी इधर से आ जाओ. You can come from this side now. Okay. So the remaining part is taking care of this, making a spreader grafts, a columnar strut, and then our job is done. So another 30 minutes and I think we should be over.
So what is the plan about asymmetrical tips?
Your sound is little slow. What? I didn't get you.
What is your plan about asymmetrical strips, LS strips?
Yeah, that's what we will see. Now, the part of the septum and the part of the upper lateral cartilage, there will be asymmetry, and we have to see what you have to trim. So, off reach, then, please. Yeah, give me wash.
You can see that prominent cartilage there.
Yes, exactly. So that's a upper lateral cartilage and a part of a septum, which was giving us. Yeah, can you see this part? Yeah. So that's a upper lateral here. So that's a upper lateral side, upper lateral cartilage on the right side. That's a septum here. That's upper lateral cartilage on the left. So I have told you the upper lateral cartilage on the left is on the higher side. Yeah, you can see it's really thick and a big, which is pressing here. So if we correct like this, then that part will go off. It's going. Yeah. So no, wait, suction then please. Bus. Yeah, hold it. Hold the off reach. So that's upper lateral cartilage, which is a little on the higher side as compared to the left side. So can you see the left side at Hina, please? Aise mat kar, aise kar. It's okay. So the upper lateral cartilage is at this level, at the level of my Caesar, thoda upar kar, and the upper lateral cartilage here, why there is sudden bleed, just suck and mop, it's at the higher side. Can you appreciate? Take a C-shaped retractor otherwise. So, just suck it here. Yeah, give a wash. थोड़ा प्यार से भी कर सकती है. Yeah. So second artery. Yeah. So thoda ढीला. Yeah. Okay. And here. think we have lost the sound again.
Hello?
Hello? 15 number bleed. I think we have lost this. Audio, I think, is gone. So I hope they are hearing. So I'm just trimming the thickened part of the
Yes.
septum. Yeah. Which was giving that deviation. So that there will be a good symmetry. Off reach then? Just suck it out. Like adrenaline pack there at the
Hello?
Hello? I think there is some problem with the audio.
Hello?
Suddenly it goes off. Hello?
Yes, we are
Yeah,
here.
yeah. Okay. Some audio problem in between. You are saying something or
No,
because
no,
I have
no.
missed?
No.
No, okay. Okay, right. So just trim this part. Either you can do it with a sharp scissor, hold it, or you can do it with a knife.
Hello?
Yeah.
If the cartilage is displaced or fractured
Uh-huh.
when you do osteotomy, then how will you manage? Like in the keystone area,
If the cartilage is displaced. Sometimes what happens is because of your osteotomy, if it is blunt, then because of that you get a displacement of, thoda pyar se please.
in the bony cartilaginous junction,
Yeah, if
keystone
it
area.
get displaced, then even then you can just remove it. You do osteotomy and then later on you fix it drilling the nasal bones.
Okay. Drilling is like you have
Then
to
you have
suture.
to repair that K junction there. So that's a septal. So
what is the plan now? Like
plan is harvest spreader grafts,
okay.
columnar stud.
Okay.
So these are two spreader graft, then a columnar stud. So I'll put I'll put something
The rim.
in a rim, yeah. Number blade has gone. So
Sir, any particular dimensions for a spreader graft you follow, sir?
yeah, sure, I will show you that. Then I will keep something for tip. We may not require it, but then because the rest entire cartilage will go for dicing. So
If you feel the cartilage is not enough, then what is the plan, sir?
then harvest rib.
Rib or conchal cartilage?
No, because conchal cartilage will have a curvature, and a good straight spreader graft will be very difficult from conchal cartilage. Conchal cartilage will be good for a folded conchal cartilage will be good for columnar stud, but not as spreader graft.
You can use the preserved cartilage, preserved septal cartilage.
No, so that's a block. and I'm going for 1.5 mm thick spreader grafts. In female, generally I will go for 1 mm. So here it's little thick because this guy has got a big face. Cut lena, please. Yeah. So I'll just trim this cartilage so that I get a even spreader grafts. Now spreader grafts will give you a good support to the septum. It will give you a good dorsal lines, and